Well, it's 7 o'clock, and thank you all for coming to this special edition of Wednesday Night at the Lab, which is going to be UW Philosophers at Work. I'm Tom Zinnan. I work here at the UW-Madison Biotechnology Center. I also work for the Division of Extension. And on behalf of those folks, thanks again for coming to Wednesday Night at the Lab. We're also co-organized by Wisconsin Public Radio, PBS Wisconsin. Sorry about that, Tina. And UW Alumni Association and UW-Madison Science Alliance. And we do this every Wednesday night, 50 times a year by Zoom. Next week, we'll have Bill Belcher here. He's a forensic anthropologist and archaeologist from the University of Nebraska-Lincoln. And he's going to be talking with us about recovering and identifying remains of US Marines from the first Battle of Macon Island, which was in August of 1942. It actually happened on the same dates as the raid on Dieppe, which got a lot more press. That was the Anglo-Canadian raid on the part of France. But at the same time, there was a raiders, Marine Raider Battalion attacked this island of Macon. And so that's what Bill does. He is an archaeologist who goes around various places in the world trying to recover remains of service people. On April 7th, David Gagnon will be here. He runs the Field Day Lab. That's part of the Wisconsin Center for Education Research. And that's all about how do you develop online games to enhance teaching and speed learning and help with evaluation. On April 9th, we're going to have a special Friday night edition of Wednesday Night at the Lab. It's part of the UW Science Expedition's annual open house, which is going to run April 9th, 10th, and 11th. Alas, this year it has to be online, but there's a great lineup of items online. And one of them is going to be this Friday night edition of Wednesday Night at the Lab. Tracy Holloway from the Nelson Institute and Bassam Shakashiri from chemistry will be here talking about a view ahead for climate change. On April 14th, Mary Haney from the School of Pharmacy will be here to talk about the development of COVID vaccines, remain for a lot of us tonight. On April 21st, Matthew Edney from the History of Cartography project here at UW-Madison, and also he's at the University of Southern Maine, will be giving us a Zoom on some of the latest work that he's doing in the history of cartography. So that's the things that are coming up. By the way, if you've registered for Wednesday Night at the Lab, you'll be able to use the same Zoom link that you're using tonight for all these other Wednesday Night at the Labs, including the Friday night edition on April 9th. Now it's my pleasure to introduce to you Professor Michael Teitelbaum. He's the chair of the Department of Philosophy here at the University of Wisconsin-Madison. I'm very pleased and grateful that we have this partnership to be able to do UW Philosophers at Work as part of Wednesday Night at the Lab. Delighted that PBS Wisconsin has been recording these also. And I'd like to introduce you now to Professor Teitelbaum.
Hi there, welcome. As Tom just said, I'm Mike Teitelbaum, chair of the philosophy department here at the University of Wisconsin-Madison. And it is my pleasure to welcome you to this year's installment of our UW Philosophers at Work series. I have some people to thank. I want to thank Tom and our co-sponsor for tonight's talk, Wednesday Nights at the Lab. I also want to acknowledge the Charles Manthey Winter Special Philosophical Events Fund, which has helped fund this event. Thanks to a few people, thanks to Rita Richter in the philosophy department office for organizing, to Be a Mum, who's managing the Zoom room for us tonight, and to PBS Wisconsin for making our broadcast happen. Tonight, we're going to start with the presentation for about 50 minutes, followed by a live Q&A with our speaker. So I'm going to introduce the speaker in just a few minutes. The presentation will happen. After the presentation, I will give you instructions if you'd like to ask a question. In the meantime, please keep your microphone muted during the presentation. So our speaker tonight is Paul Kelleher. Paul is Associate Professor of Bioethics and Philosophy at UW-Madison. His teaching and research focus on ethical and philosophical issues concerning public policy, especially health policy and climate change policy. He has published scholarly work on the foundations of justice in healthcare, the moral evaluation of inequalities in health outcomes, the ethics of rationing healthcare, the role of paternalism in the practice of public health, philosophical issues in health economics, and clinical ethics issues such as conscientious refusal by health professionals and the treatment of severely disabled newborns. Most recently, he's just finished writing a book on philosophical issues in climate change economics. More to the point for tonight's presentation, Professor Kelleher serves on the ethics committee at University Hospital here in Madison and is the chair of the advisory committee for University Health Services, which is the student health center here at UW. In 2018, he was elected a fellow of the Hastings Center, the nation's oldest bioethics institute. And since the start of the COVID-19 pandemic, Professor Kelleher has served on 2 state-level committees concerned with the allocation of scarce medical resources, as well as a rapid response ethics committee at University Hospital. Given his scholarly expertise and his real-time engagement with these policy issues that are affecting all of us these days, I personally can think of no one better to speak to us about the ethics of vaccine allocation. So please join me in welcoming Professor Paul Kelleher. Paul.
Thanks a lot, Mike. Thanks, Tom, and all of the sponsors and organizers for tonight's event. And thanks to all of you for coming to watch. Mike, you'll give me a thumbs up. You can hear me okay, right? Yep, wonderful. So what you're going to see imminently here is a recording that we made recently in collaboration with PBS Wisconsin of the talk, the meat of tonight's event. And then after that's over with, we're going to look forward to having a Q&A with you in the audience. So you might notice that I'm wearing different clothing and that there's not a window behind me when the video rolls. And that's because this was recorded late last week. So I don't have anything else to add by way of preface. I'll do a little bit of that in the recording, and I'll look forward to seeing you all on the other side.
Thank you very much for that introduction. Since the COVID-19 pandemic began, I've served on several coronavirus-related health resource allocation committees. For example, I'm a member of the Rapid Response Ethics Committee at the University Hospital in Madison, which provides guidance on the allocation of scarce critical care resources, such as ventilators, ICU beds, and other therapies. And I've served on a state-level committee that wrote allocation guidelines for scarce COVID-19 therapeutics, such as the monoclonal antibody treatment given to President Trump during his COVID-19 infection. Today, I'm going to talk about the ethics of vaccine allocation. I have 3 goals. First, I want to explain where explicit thinking about ethics and ethical principles has shaped the actual vaccine allocation process that's now unfolding across the state and indeed across the country. Second, I want to demonstrate what it looks like to engage in substantive analysis of ethical claims. And finally, I want to give you a sense of how Wisconsin is doing in this challenging, unprecedented, and ongoing vaccine allocation effort. I'll share these impressions not only as a bioethics scholar and a concerned citizen, but also as a former member of the state-level committee that was tasked last year to write the ethics principles to guide this entire enterprise. Of course, I'm just one among many members of that committee, and like everyone else, I can't and I don't claim to be perfect in lacking bias of one kind or another, and in having properly weighed all of the ethical principles and values that I'll be talking about. But I've done my best to evaluate the situation impartially, and my main aim is to put some ideas and arguments forward in the public sphere for others to discuss, criticize, modify, and maybe even accept. So let's start in late summer of 2020. At some point in August, staff at the Wisconsin Department of Health Services, or DHS, began to put together an ethics subcommittee of the State Disaster Medical Advisory Committee, or SDMAC. SDMAC is a standing committee of 12 members that advises DHS leadership regarding medical ethics during a declared disaster or public health emergency. The SDMAC Ethics Subcommittee that was convened in late 2020 had the charge of drafting a document that outlined ethical principles that should guide the state level allocation of scarce COVID-19 vaccine and therapeutics. And I served on this ethics subcommittee along with 15 other Wisconsinites from a diverse array of backgrounds. We had representation from community health centers and tribal health systems, the disability rights community, AARP Wisconsin, clinical and public health ethics, and several health and social service and advocacy organizations that serve many different communities across the state. The plan was for the SDMAC ethics subcommittee to draft ethics principles and other high-level ethics guidance that would then be released for public comment and then finalized by the committee. And then, if approved by the larger standing SDMAC subcommittee, be passed along to two other committees that were going to be responsible for writing concrete recommendations for vaccine allocation and for therapeutic allocation. DHS would then make its own decision whether to accept, reject, or modify these subcommittees' recommendations before implementing an official allocation policy of the sort that we see now. What I want to do in this talk is to explain both the process and some of the ideas that underlie the allocation framework and the vaccine eligibility criteria that now prevail across the state. So let's begin with the SDMAC ethics subcommittee. While COVID-19 trends in August 2020 had improved from the prior spring, it was clear to all of us on the ethics subcommittee that we were by no means out of the woods and that any return to normal would require widespread vaccination. And of course, vaccination not only provides the community benefit of lower disease prevalence in general and affords individual benefits to those who are undergoing vaccination. This is a personal health benefit that comes in addition to whatever benefit that we get at the community level. So our committee had to consider both the ethics of pandemic mitigation at the community level, as well as the ethics of equitable resource allocation to individuals, each of whom may want vaccination and who may carry a different degree of personal risk of contracting COVID-19 or of severe illness or even death, of course, if infected. Because the ethics subcommittee included members who don't normally engage systematically with medical and public health ethics in their day-to-day activities, and because we were in the midst of an ongoing pandemic that created real urgency for us, the ethics subcommittee wanted to get started without having to reinvent the wheel, so to speak. So we were asked by the subcommittee co-chairs to review previously issued ethics documents. And one of these was a document produced in 2008 by an ethics panel in collaboration with Wisconsin Hospital Association and the Wisconsin Division of Public Health. Now, as with virtually every ethics framework that I've seen for guiding resource allocation in the current pandemic, this earlier 2008 document helpfully distinguished between two sets of ethical values or ethical principles. On the one hand, there are the ethical values that bear on what makes for socially responsible allocation. Call these the substantive ethical values, since they bear on the substance of the issue at hand. Second, the 2008 document also stressed the importance of what it called procedural values. So think of these as values that all public decisions of immense consequence should respect and embody. Examples of these include the value of being based on well-established scientific evidence, the need for public decision-making to be carried out in a transparent, open, and inclusive manner, in a manner that doesn't exclude or silence, but is affirmatively responsive to the concerns and inputs of the wide diversity of Wisconsin residents. These and potentially still other procedural values are obviously extremely important. And the state ethics subcommittee that I served on drafted its own similar list. But in the interest of time, I'm going to focus in this talk on the other so-called substantive values and principles, as they're the ones that purport to speak directly to how different groups should be ranked for prioritization when the task is allocating scarce healthcare resources, such as scarce doses of vaccine. So now consider this substantive ethical principle that comes from that earlier 2008 document. This is a principle that speaks to fairness. It says This value requires that healthcare resources be allocated fairly, with special concern that the most vulnerable are treated fairly. However, given the fact that there will be limited resources, the fair distribution of resources is governed not by what is best for the individual, but rather by the principle of the greater good of the community. So that was the principle from that 2008 document. Notice the however in the middle of the principle. This, however, suggests that there is, or at least can be, a conflict between treating people fairly on the one hand, and on the other hand, promoting what this document calls the greater good of the community. And indeed, that's a very common distinction in ethics as an academic discipline. Sometimes it's possible to promote health or well-being a great deal, but to do so would require neglecting the needs of those who are worst off. Now, here's a philosopher's thought example to make the point. Suppose that for whatever reason you found yourself in the unfortunate position of having to choose which of two groups to help, and you can't help both of them. So suppose, for example, that group A contains just two people, both of whom are very ill and who will die without your assistance. And that if you choose to help them, you could prevent both of them from dying. Or, and this is option 2, you could choose not to help group A, and instead you could help group B. Now imagine that group B is such that no one in the group faces any risk of dying, but that if you don't help group B, all 10,000 members of the group will lose their sight for the rest of their lives. Now, obviously, this is a very academic philosopher's thought experiment. It tells you very little backstory, and it asks you to imagine that no other ethically relevant factor distinguishes one group from the other. But the example is intended to illustrate a conflict, at least at the conceptual and theoretical level, between helping the worst off on the one hand and doing the most good on the other. It's a choice between helping those who will be worse off if not helped. These were the two people in group A, and helping the group that is so large that you could do more overall good if you help them, even if no individual in that group faces anything nearly as bad as death. So anyway, I hope that you can see what it might look like for there to be a tension between aiding the worst off on the one hand and producing the most overall aggregate benefit on the other. But now notice if there is such a possible tension, then really that proposed principle of fairness that we just talked about in the 2008 document really could be broken down into two different principles. First, you could have a principle of fairness, which concerns perhaps showing special concern for those who are worse off or who will be worse off if not helped. And second, a principle that we might call the greater good principle, which articulates the ethical importance of policies that produce as much health and well-being as possible in a community. So, here you have an example of just the sort of conceptual slicing and dicing that academic philosophers like me are kind of obsessed with. So now that fairness principle from the 2008 document is just one principle from one framework that the Wisconsin COVID-19 Ethics Subcommittee considered when we were doing our work. We were also very fortunate to have, as a second example, a report that was written and released in the fall of 2020, just as we were doing our work by the National Academies of Sciences, Engineering, and Medicine. The National Academies is a collection of experts in fields relevant to public policy, and it's often tapped by Congress and federal agencies to study and to make recommendations regarding matters of pressing public importance. And that report, the National Academies report, was a major event. It was always clear that the federal government and the 50 states would look to the National Academies framework as they themselves grappled with these allocation issues. And that's exactly how our ethics subcommittee at the state level used that report too. So what did the National Academies say? Well, in addition to articulating its own set of procedural principles and values, it put forward 3 substantive ethical principles to guide vaccine allocation. These were a principle of maximum benefit, a principle of equal concern, and a principle of mitigation of health inequities. Now, the maximum benefit principle is pretty similar to the greater good of the community principle that we considered just a moment ago. But the National Academy stressed that in considering the extent to which an allocation strategy creates benefits, policymakers should focus not only on health benefits like the prevention of illness and death, but also on socioeconomic well-being, the sort of thing afforded by in-person education and reduced unemployment. Now, under the heading of equal concern, the National Academies stress that no one person is intrinsically more valuable or worthy of consideration than any other person, and that equitable vaccine allocation mustn't prioritize people purely on the basis of religion, race, ethnicity, national origin, disability, or age. But at the same time, the National Academies stress that it's absolutely possible to show equal concern and equal respect while also prioritizing some groups over others for the purposes of phased vaccine allocation. To take an example that hits very close to home, it doesn't show me less than equal concern or less than equal respect to put me at the very back of the vaccine allocation line, given that I am a healthy university professor who can fulfill my essential job duties safely from my home. When vaccine doses are scarce, the aim of any allocation framework must be to prioritize some over others on the basis of principled moral reasons rather than on the basis of reasons that in fact offend against the equal moral status of any individual. So the National Academy's final substantive ethical principle was one of mitigation of health inequities. And health equity is defined in different ways by different people. The National Academies adopted a definition on which health inequities are, quote, systematic differences in the health status of different population groups, which have significant social and economic costs both to individuals and to societies, end quote. A paradigmatic example of a health inequity is the difference in life expectancy between white Wisconsinites and black Wisconsinites. According to the most recent data available on the state's website, white Wisconsinites on average live 6 years longer than black Wisconsinites. And according to a recent report by the Pulitzer Prize-winning nonpartisan news organization ProPublica, the white-black life expectancy gap is a staggering 14 years inside the city of Milwaukee. Now, health inequities just like this reflect systematic differences in opportunities to live a full, healthy life, and the National Academies maintained that these differences in opportunities and outcomes are rooted in structural inequalities, racism, and residential segregation, and that, to quote them, any vaccine allocation scheme designed to reduce COVID-19 must explicitly address the higher burden of COVID-19 experienced by the populations affected most heavily, given their exposure and their compounding health inequalities. Here, for example, are two diagrams produced by the award-winning American Public Media Research Lab that illustrate the sort of health inequities that the National Academies group was referencing. This diagram shows the comparatively higher risks of dying from COVID-19 faced by people of color across the entire country. For example, when adjusted for age, Latinos are 2.4 times more likely to have died than white Americans, while Black Americans are twice as likely. Now, the second diagram displays Wisconsin-specific data. This shows, for instance, that when adjusted for age, the Native American population of Wisconsin has seen 309 COVID-19 deaths per 100,000 residents, compared to 105 deaths per 100,000 white residents. Such are the health inequities that the National Academies emphasized must be explicitly addressed in vaccine allocation. So those were the National Academy's three substantive ethical principles: maximum benefit, equal concern, and the mitigation of health inequities. And in the end, this set of principles was very similar to the principles that our Wisconsin Ethics Subcommittee recommended to the state. There were some differences, but in my opinion, they're mainly differences in presentation and not significant differences in substance. For example, instead of maximizing benefit, the Wisconsin subcommittee stressed the importance of promoting the overall common good, as well as the requirement that every resident be treated with equal respect and dignity. And we also put forward a principle calling for attention to and mitigation of pre-existing health inequities. We called in particular for the state and for vaccinators to attend to individuals and groups' risks by accounting for what we called the compounding multiple risk factors associated with COVID-19. And finally, like most other major ethical frameworks released in the fall, our Wisconsin Ethics Subcommittee articulated a list of procedural considerations that stressed the importance of transparency, being trustworthy, and inclusivity. Now, as I've said, the Wisconsin Ethics Subcommittee that I served on was tasked with drafting ethics principles and general guidance, and we were not tasked with proposing concrete vaccine allocation phases of the sort that are now being implemented. But the National Academies did propose phases, and let me show you what their proposal looked like. You can see that the National Academies proposed phase 1 includes several groups who are at high risk of COVID-19 exposure and or severe illness if infected. The National Academies phase 1A, which are called the Jumpstart phase, focused on high-risk healthcare personnel and first responders, two populations that were essential for the ongoing COVID-19 response in all states. And after that, the main focus was on individuals whose absolute risk of dying was deemed the highest. For example, people with high-risk medical conditions and adults residing in congregate living settings, especially older adults. Now, I'll show you some data on those populations in a moment. For now, just notice that in its phases 1 and 2, the National Academies group appears to have prioritized populations on the basis of their elevated COVID-19 risks, or in some cases on their role in maintaining social functioning. You can see, for example, that older adults not included in phase 1 is listed last among the National Academies phase 2 priority groups. Compare that to some states such as Maine, where I'm from and where my family still lives, that's been using an exclusively age-based approach to vaccine allocation. By contrast, the National Academies understood that while risk of hospitalization and death worsen with age, other non-age risk factors can be equally, if not more, concerning. And they must also be considered for prioritization. I'll return to this point in just a moment. So take a look now at the brown oval beneath the National Academies' proposed phases. The National Academies proposed to respond to health inequities by treating equity as a so-called cross-cutting consideration. Specifically, it proposed that in each group singled out for prioritization in each of the phases, vaccine access should be prioritized for geographic areas based on the CDC's Social Vulnerability Index, which is an index that was developed for local preparedness in public health emergencies, exactly of the sort that we're in right now. The index identifies geographic areas of vulnerability based on 15 census variables, which reflect many of the recognized social determinants of health. In general, the National Academies proposed that vaccine doses be allocated largely on the basis of individual risk, and then proposed that the Social Vulnerability Index be used to make even finer grained sub-prioritizations within those risk categorizations, within those risk groups. Now, while I think there's much to commend this general approach to prioritization, I, along with two other bioethics colleagues, submitted a public comment to the National Academies underscoring something we thought was very important. We noted that many individuals at elevated risk for severe COVID-19 outcomes may lack access to the very healthcare that would lead to the very medical diagnoses of comorbid and underlying conditions that the National Academies referred to in its phase 1B proposal. After all, a central dimension of health inequity is the degree to which members of socially marginalized groups have been historically disenfranchised from access to affordable healthcare services. To the extent that vaccine eligibility was going to be policed, that's to say, to the extent that individuals were going to be asked to prove whether or not they had hypertension or diabetes or asthma, then barriers to affordable healthcare could translate into barriers to much needed protection against COVID-19 risks. As a way to mitigate these background inequities, my colleagues and I proposed a place-based approach. This is an approach where priority would be given to geographic areas where social vulnerability is high and where vaccinating entities would engage in proactive outreach rather than in passive internet-based scheduling for vaccination. Unfortunately, these suggestions were not ultimately incorporated into the final draft of the National Academies report. Now, as I've mentioned, our Wisconsin Ethics Subcommittee guidance was intended to inform the work of a separate state-level vaccine subcommittee. That second subcommittee began its work around November 2020, and it issued its first official recommendations to the state in December. That timeline enabled the state vaccine subcommittee to respond to recommendations from the CDC, which were informed by the Advisory Committee on Immunization Practices, or ACIP. That's a group of medical and public health experts who develop recommendations on the use of vaccines in the United States. And they've recommended vaccine schedules for childhood immunizations, and now they were tasked with doing the same in this context. Now, I want to turn to ACIP's decision-making in November and December of 2020, because I think it reveals important lessons both for the substantive ethics of vaccine allocation, as well as for how meaningful ethical analysis, as well as well-meaning ethical analysis, can misfire. Okay, so after uncontroversially prioritizing healthcare personnel and residents of long-term care facilities in phase 1A, the ACIP turned its attention next to its other phases, which are called phase 1B and 1C. At a meeting just before Thanksgiving in November 2020, ACIP staff presented key epidemiological background information along with 3 options for phase 1B prioritization. So let me first show you some of the data that ACIP considered, and then we'll examine how ACIP attempted to analyze the decision from the perspective of ethics. The 3 populations that ACIP considered for phase 1B prioritization were non-healthcare essential workers, which was a large category that encompassed nearly 90 million people, adults aged 16 to 64 with high-risk medical conditions, and the third group was adults ages 65 and older. The task was to choose which of these groups would be vaccinated in phase 1B and which would wait until phase 1C. ACIP proposed to analyze this decision along 3 dimensions. These were the underlying clinical and epidemiological science, the feasibility of implementation, and ethics. Regarding the science, let me show you just 2 of the several slides that ACIP staff presented at the November 2020 meeting. This is a slide showing relative risks for COVID-19 associated hospitalization. Take a look first at the right-hand side of the table. These are so-called adjusted relative risks. That is, they've been adjusted for age, sex, and race and ethnicity. Look first just below the red box. Here it's reported that those 65 years and older face a bit more than 2.5 times the risk of being hospitalized with COVID-19 as compared to the specific reference group of individuals ages 18 to 44. Now look inside the red box. This shows that individuals with 1, 2, and 3 medical conditions have 2.5, 4.5, and 5 times the risk of COVID-19 related hospitalization as compared to individuals with no underlying medical conditions. Finally, you can see on the right-hand side at the very bottom that individuals who are Black or who are members of other racial and ethnic minority groups face risks that are between 3 and 4 times higher than those faced by non-Hispanic white individuals. Each of these findings reported in this chart is certainly relevant to the question of which of these 3 groups ACIP should have prioritized in phase 1B. I have no question about that. While older age is definitely a serious risk factor, so too, as you can see, is having certain pre-existing medical conditions or being a member of a racial or ethnic minority group. Relevant too is that because of background differences in baseline life expectancy, the 65 and older group is disproportionately white, whereas racial and ethnic minorities make up a disproportionate share of those with high-risk medical conditions, as well as those who are non-healthcare essential workers. Okay, here now is a second slide that was shown by ACIP staff at the November meeting. This slide compares the proportion of deaths that would be prevented over the 6 months following the implementation of phase 1B, depending on which group was prioritized for 1B and which were prioritized for phase 1C. And the diagram also reports on expected deaths averted in 2 different scenarios. First, on the left is the scenario in which COVID-19 incidence is rising in the population, as it was expected to do in December following the Thanksgiving holiday. You can see on the right the scenario in which incidence is falling. That's the modeling in that scenario. So let's focus on the first scenario, the one where on the left where incidence is rising. What ACIP's modeling suggested is that though slightly more deaths would be averted if those 65 and older were prioritized in phase 1B, almost as many deaths would be averted if either of the other two groups were prioritized instead. Meanwhile, prioritizing those 65 and older would not prevent as many COVID-19 infections as would prioritizing those with high-risk medical conditions or essential workers. So on the assumption that preventing overall deaths is important, but not necessarily the only important thing, because infections that don't result in death matter too, many people found it difficult to conclude on the basis of this epidemiological modeling alone which of the groups should be prioritized. And indeed, that was ACIP's opinion as well. They said that in their view, the quote, differences among three prioritization strategies were minimal, end quote. So ACIP declared that the decision should turn on considerations of implementation or feasibility, and then on ethics. Since the potential long-term effects of non-fatal COVID-19 infection are not insignificant, and since, as we've already seen, a person's individual risk of dying is strongly correlated with their medical history and with their race and ethnicity, ACIP staff believed that vaccine prioritization could not be determined on the basis of the epidemiological science alone. Now, because my focus is on ethics, I'm going to skip over ACIP's discussion of implementation. In general, ACIP believed that overall, essential workers and those with high-risk medical conditions would be somewhat harder to reach than individuals age 65 and older, and we'll come back to that. So acknowledging that that's a topic that I'm going to skip over, here's where things stood before the ACIP panel turned to consider ethics. On a straightforward reading of ACIP's plus-based tally system, it seems that adults aged 65 and older are slightly ahead, with the other two groups not far behind going into the consideration of ethics. So now let's take a look at how the ACIP proposed to analyze those ethics. Just like the national academies, the ACIP adopted a principle of maximum benefit, a principle concerned with mitigating health inequities, but then it also adopted a new principle, or at least a principle with a new name. It termed this principle the Promote Justice Principle. In a background white paper released around the same time in November in 2020, ACIP staff, or I think this was possibly CDC staff, said that the Promote Justice Principle was described, or could be described as, quote, intentionally ensuring that persons have equal opportunity to be vaccinated, where this includes a commitment to removing unfair, unjust, and avoidable barriers to vaccination that disproportionately affect those that have been economically or socially marginalized, end quote. With that in mind, let's take a look at the ACIP's key ethics slide. This slide purports to compare the three populations under consideration with respect to each of the ACIP's three ethics principles. At the November meeting where this was discussed, the ACIP presenter noted that a darker green color indicates stronger support for that ethical principle. For example, in looking at the first row of the table, ACIP is saying that vaccinating essential workers and adults 65 and older does better when it comes to maximizing benefits and minimizing harms than does vaccinating adults with high-risk medical conditions. Curiously, though, neither the ACIP nor the background white paper that it cited gave any explanation for why a lighter green shade was given to the option of vaccinating those with high-risk medical conditions. And after all, we've already seen that the epidemiological modeling that the ACIP considered showed that prioritizing adults with high-risk medical conditions would avert both more infections and more deaths in the 6 months following vaccination than would vaccinating essential workers instead. Take a look now at the second row of the table. Here, ACIP reports that, in their judgment, prioritizing essential workers does better with respect to promoting justice than would prioritizing those with high-risk medical conditions or older adults. But once again, ACIP didn't explain why it drew this conclusion. And recall that the ACIP's ethics principle concerned with promoting justice says that all persons should have equal opportunity to be vaccinated and that there should be a commitment to removing unfair, unjust, and avoidable barriers to vaccination, barriers that disproportionately affect groups that have been economically or socially marginalized in the past. And if you look at the very middle box, you'll see that ACIP seems to warn that if those with high risk medical conditions are from disadvantaged backgrounds, from socially marginalized backgrounds, then they will require focused outreach. As they put it, focused outreach to those with limited or no access to healthcare. That, if you recall, was precisely the point that I and my bioethics colleagues stressed in that comment that we submitted to the national academies. But here's a question. Why should this fact, which warns about a need created by historical and systemic inequity, translate into a lower score for a group that disproportionately faces that very inequity? The ACIP never explained this, and I admit that I'm still pretty mystified by it. Now look at the final row of the ACIP's ethics table. You'll see that ACIP thinks that prioritizing essential workers does much better with respect to mitigating health inequities. And here too, they cited more or less the same phenomenon that I and my colleagues had flagged earlier. Namely, that historical and inequitable barriers to healthcare access can prevent those who are burdened by health inequities from receiving diagnoses of high-risk medical conditions in the first place. ACIP also noted that the group of individuals age 65 and older is whiter than the United States population, something that I've already mentioned. And this, to them, suggested that if those 65 and older were prioritized, it would unfairly restrict access to vaccination among people of color. Now, as I mentioned, each of these observations is accurate, but the question is this. Given how issues of equity intersect with all three of these population groups, do these observations that the ACIP flagged, do they justify giving such different scores to the three groups on the ethical principle of mitigating health inequities? The ACIP never really gave a satisfactory rationale for where they came down on that. The ACA, clearly they thought that their considerations did justify that, but it didn't present an argument in favor of the conclusion. Instead, it simply translated the judgments it expressed with its shades of green into its plus-based tally system like this. Now, at the time, many commentators chose to focus on the ethics scores that ACIP gave to the groups of older adults, that is, the scores that are listed in the rightmost column. By contrast, I've just raised some questions about the scores given to adults with high-risk medical conditions. That's the group listed in the middle column. Not only do I myself not understand why this population didn't receive 3 pluses along the dimension of maximizing benefits, or why it received just 2 pluses for promoting justice, but if the way that justice were promoted in this population was to use proactive outreach to those communities who are most likely to be burdened by multiple high-risk medical conditions, then I don't see why the high-risk adults option should also be scored so low along the dimension concerned with health equity. After all, the National Academies already flagged that the CDC's Social Vulnerability Index, and that it was a tool that could be used to address precisely the barriers to access that led ACIP to give just a single plus to the option of vaccinating those with high-risk conditions. Nevertheless, here in the bottom row is how the ACIP summarized its overall ethics discussion. And from the table as a whole, you can see why ACIP ended up prioritizing essential workers in its November recommendations, even though adults age 65 and older seem to be in the lead, so to speak, before going into the discussion of ethics. You can see that if adults 65 and older had gotten just 1 more plus on ethics, or if ACIP had better appreciated the equity-based merits of proactive outreach and vaccination of individuals who live in areas of high social vulnerability, who are comparatively more likely to have high-risk medical conditions, then at least one of these other groups may well have been tied with the essential workers group. Now, I want to make it clear that I'm not stressing this because I'm somehow against vaccinating essential workers. Of course, I'm for vaccinating anyone and everyone who chooses vaccination for themselves. I simply want to emphasize 2 things. First, it's not as easy as it might look to shoehorn a subtle, complex ethical analysis into a simplified plus system as the ACIP sought to do. And second, I want to highlight that the ACIP's choice to downgrade the option of vaccinating individuals with the highest risk conditions seems to have added a further disadvantage on top of the pre-existing disadvantages that lead so many of those individuals to be at greater risk to begin with. The ACIP was absolutely correct to highlight the fact that high-risk individuals in high social vulnerability areas will require focused outreach for vaccination. But that should be acknowledged and navigated as an unjust barrier to access. It definitely should not be cited as a reason for the conclusion that it's less ethical or less ethically compelling to vaccinate adults with high-risk medical conditions than it is to vaccinate the entire category of essential workers, many of whom are young and at comparatively lower risk of severe outcomes of COVID-19 infection. Of course, there are individuals who have high risks in the essential worker population. And basically what I'm saying is that the three categories that the ACIP worked with may not have been the best three categories to treat as exclusive comparators. Ultimately, ACIP's November recommendation was to suggest that essential workers should be prioritized under Phase B, and that Phase 1C should include all adults age 65 and older, and that it should also include all individuals 16 to 64 who have high-risk medical conditions. Prior to the vote on this proposal, many voting ACIP members cited considerations of equity as the main reason to prioritize essential workers, and I've tried to raise some questions about that line of thinking here. Nevertheless, and in the end, that was not ACIP's final 1B and 1C recommendation. The November vote was just a preliminary vote, and the final vote was to come in mid-December. And in that vote, the ACIP radically changed course. It recommended that Phase 1B comprise frontline essential workers and persons 75 and older. Gone too was any reference to the plus system and really any concrete rationale for the major change from November to December. Accordingly, there was no affirmative reason given for why it was equitable to delay vaccination among those with high-risk health conditions who live in high social vulnerability areas. It was left up as a question mark. With all that said, the category of frontline essential workers does include many people who face enormously high COVID-19 risks. Key among them are individuals who work in meatpacking plants within the food and agriculture sector. This is a sector, an industry that's seen ongoing and severe outbreaks of COVID-19 all the way through the pandemic. And those who are employed in the sector live in areas of the country that rank comparatively high on the social vulnerability index. So that is a key demographic that creates overlap between very high-risk individuals and essential workers. But notice that this sector could have been the focus of an explicitly place-based approach to vaccine allocation, rather than an approach that combined an age-based criterion with a still very wide employment classification-based criterion. Now, ACIP's final 1B recommendation was accepted by the CDC director in late December 2020. And around that same time, the Wisconsin State Vaccine Subcommittee took up the issue of what the state's 1B priorities should look like. After several weeks of deliberation, many of which I watched in early morning Zoom sessions, the state committee proposed the following groups be included in Phase 1B. Those 70 years and over, Wisconsinites who are the recipients of IRIS and family care, a group that includes frail elders and adults with physical and intellectual disabilities, individuals who reside in congregate living settings, for example, homeless shelters, jails, prisons, mental health institutes, and various public-facing and frontline essential workers, including non-EMS first responders, educators, and non-frontline but essential healthcare personnel. As you can see, many of these state-level recommendations departed from ACIP's December recommendations. The Wisconsin subcommittee was, in my view, much more sophisticated in its deliberations on how to craft vaccine allocation priority schemes that harmonize the two ethical principles that virtually all ethical frameworks included: a principle concerned with promoting benefits or maximizing benefits, and a principle concerned to mitigate health inequities. Especially important for these two principles is the committee's focus on congregate living settings, where individuals who disproportionately hail from high social vulnerability index areas are brought together, and where COVID-19 transmission is comparatively high and relatively more difficult to keep in check. At the same time, the Wisconsin subcommittee was finalizing its 1B recommendations. President Trump's outgoing Department of Health and Human Services secretary called for every state to broaden its vaccine eligibility to everyone 65 and over and everyone who had at least one high-risk medical condition. And very soon after that, Wisconsin adopted the vaccine subcommittee's 1B recommendations with two key changes. That age-based eligibility would be lowered from 70 to 65, in line with what the Trump administration had asked of states, and that educators and childcare professionals would be given priority among those who would be eligible in phase 1B. Now, I want to make it clear that I am glad for all of those. I'm ecstatic for all of those who have been vaccinated under 1B or who might have maybe even have an appointment in the future, near future, I hope. But I also feel an obligation to flag the important trade-offs, the important ethical trade-offs that are embodied in the approach that Wisconsin ultimately adopted for phase 1B. These are trade-offs that were starkly underscored by a statement from a DHS official that was quoted in a news story on March 10th. This is a story that announced that the state was beginning to consider who would be eligible in a future phase 1C. The official explained that the state was trying, quote, to include in phase 1C the people who we know are at risk, to think about how do we do this in a way that doesn't overwhelm the vaccinating system, end quote. In light of this concern to avoid overwhelming the vaccine allocation system, I think it's immensely important to stress that the decision that was made in January, the decision to make everyone over the age of 65 eligible for vaccination then in January, that was a decision that meant that many individuals who face the very highest risk of adverse effects and who may also live in areas ranking high on social vulnerability would have to wait all the way until March 22nd, when they will finally become eligible for COVID-19 vaccination under the state's phase 1C criteria. I also want to stress that this is not true of all high-risk individuals. I've already mentioned that those who reside in congregate living settings, as well as those with intellectual disabilities who are on receive benefits from certain state programs, they are already covered under 1B. People with Down syndrome, for example, have been especially hard hit by this pandemic. A large study in the United Kingdom found that if infected, people with Down syndrome are 5 times more likely to be hospitalized and 10 times more likely to die than the general population. And I think it's a real credit to the state of Wisconsin that many of its residents with Down syndrome have been eligible for vaccination under 1B. I think another bright spot from the point of view of marrying the ethical principle of maximizing benefits with mitigating health inequities is the state's policy, which was adopted in January, of filling all vaccine doses that are requested across the state by community health centers, free clinics, and tribal councils. And because Native American tribes are sovereign nations, they can formulate their own eligibility rules. And so they've been able since January to vaccinate everyone in their communities that they deem have the highest risk. And I think that the state deserves enormous credit for adopting this policy of filling all of these requests from these communities. It's a policy that empowers many underserved and marginalized communities across the state. I've been mostly talking about vaccine eligibility rules, although I've at times stressed the importance from an equity perspective of proactive outreach and place-based vaccination efforts. And I'm encouraged to see mobile vaccination units setting up clinics in, for example, churches on the north side of Milwaukee. The first of these took place in early March, as best as I can tell, and that's precisely when West Virginia, a state that has been a national leader in proactive outreach, was doing the same. West Virginia has been using the one-shot Johnson & Johnson vaccine in these efforts, and while I don't know which vaccine is being used in similar contexts here in Wisconsin, there's every reason to provide a one-and-done option to those who live in areas of high social vulnerability where residents face many constraints, including constraints on their ability to take time away from work to receive a second vaccine dose, or time away from caregiving to get through feeling a little crummy, for example, as is not uncommon after the second dose of the Pfizer or Moderna vaccines. And speaking of the CDC Social Vulnerability Index, it was announced on March 16th, just the day before I'm recording this talk, that as of March 22nd, all residents who are 18 or older in 10 zip codes in Milwaukee will be eligible for vaccination. These are zip codes that score extremely high on the CDC Social Vulnerability Index and that have borne a disproportionate share of the state's overall COVID-19 death toll. I hope that these expanded eligibility criteria will be combined with focused, proactive outreach to make vaccination easy and accessible to this newly eligible population. For example, they should take a page out of the playbook of that North Side church I just mentioned. In that case, the city of Milwaukee helped church staff, and together they sent out robocalls to parishioners and even reached out directly to some of them to encourage them to come in to be vaccinated, to tell them that that was an option for them. That sort of approach, one that doesn't require people to have routine access to the internet, it really ought to be the rule, not the exception, and I hope to see more of it. I've heard some ethicists say regarding vaccine eligibility that the question isn't who gets vaccinated, but when. Everyone will get a vaccine in due time, they say. And that certainly will be true of most of us, but it may not be true of all of us, and it's more likely to be false for those who face the highest risks. Some of them will have died before they can be fully vaccinated. And I hope that I've given some indication of what ethics, as a serious professional enterprise, can contribute to these important life and death conversations. I certainly don't have all the answers, and I know very well that a one-way monologue like this is not the ideal way to converse with one's fellow Wisconsinites, but I'm very grateful to have had this time to share my thoughts, and I want to invite you very sincerely to reach out to me via email, whenever you'd like, if you'd like to consider continuing the conversation. Thank you very much, and please be well.
Thank you, Paul. That was great. So here's what we're going to do now. We have Paul back to answer questions live, and I am going to moderate the question asking. So there are two ways that you can ask questions. You can either raise your hand, and the way to do that, if you're not super familiar with Zoom, is there's a little button at the bottom of your Zoom screen that says reactions. And if you click on that, one of the available reactions is going to be raise hand. So if you'd like to raise your hand to ask your question live, you can do that. Please keep your microphone muted until I call on you. The other thing you can do is you can type a question into the chat, and a few questions are already in the chat. Bia is going to help me sort of alternate between the chat and folks who raise their hands. Again, please don't unmute until I call on you, and apologies in advance if I butcher the pronunciation of your name, especially if you've been my colleague for over a decade. So, all right, go ahead and raise your hand if you'd like to ask a question live. We have a few questions already in the chat. One really interesting question from Raj Gopal is about Paul, it's about why the decisions are being made at the level that they're being made. So for instance, why not leave it to individual hospitals to decide on vaccine allocation policies, or to clinics or to individual physicians? Is there a good reason, maybe a good ethical reason, to have these decisions made at the level of the state or maybe even at the national level?
Yeah, that's a great question. The way it worked was the federal government, or the advisory bodies for the federal government, again, just gave advice, CDC approved advice. That was the advice that went through ACIP, through the CDC director. But really the way this worked was that all 50 states had the task of coming up with their own prioritization protocols. And I think that alone, I don't know well enough how well it might have worked if federalism in this case were set aside and there were a top-down approach. I was certainly anxious going into this, what it would look like to have 50 states do this one by one. But let's just talk about the state level as opposed to whether or not we should have had a national level. At the state level, this is a state resource. The federal government made that very clear. This is in the state. That's how the state conceived of this as well. This was a resource, a life or death resource that was put in the hands of the state, and the state had a decision to make. How do we use this scarce resource that we have? Now, of course, it could have just given allocations to hospitals and let them decide. That is in part, I think, what happened at the very first phase 1A. I think hospitals did have some discretion on how to select among their own employees during the 1A phase, the phase that was focused on vaccinating healthcare workers. And so hospitals certainly did that. But I got to tell you that I don't think there was any hospital that really wanted to have to make their own decisions about how to allocate across the larger population, their non-employee population. Only certain people in a hospital's area or on a hospital's health information in their system. So there are issues of how to do outreach. There are issues of how they would choose between people who are established patients and non-established patients. And really, we're seeing, of course, this is a major enterprise that had to be deployed across not only hospitals, but community health clinics and pharmacies. And no hospital wanted to, coordinate all of those entities. And at the same time, I think Raj, his question also asked, why can't we just leave this allocation to hospitals, including ER visits? And the one reason there is that ER visits are, of course, for emergencies and not for the sort of preventative care that a vaccine is. I do think Raj says that he recommends, or not recommend, but he was wondering in that question about giving high priority to people on Medicaid or on food stamps. And certainly those demographics would overlap considerably with individuals who rank high on social vulnerability. And so, I think those are good ideas, and the state didn't go with those.
Got it. Thanks. So we have some people who've also asked multiple questions. So I'm trying to pick one, and maybe we'll come back to their other questions later. Lawrence Winkler pointed out that he didn't see any ranking based on ability to mitigate exposure to disease. So for instance, people who are working from home versus people who have to work in an office for one reason or another, folks in senior housing versus seniors in their homes. Was that, brought into play at any point in this process?
Yes, I mean, it's hard to, of course, police within a category that's very broad, something like 65 and older. It's really hard to quote unquote police who can work safely from home, as I said in the recording that I can. But on the flip side of that, the state, from the beginning, the State Advisory Vaccine Allocation Committee was absolutely focused on finding and identifying populations whose residential status put them at very high risk for transmission. And then, overlapping with that may, in the context of older adults, living in congregate settings, also have those age-based risk factors. And so that congregate living setting, the setting that includes not only senior living or long-term care facilities, but also prisons and jails, that was part of the state's focus, at least the State Advisory Committee's focus, since December. On the heels of that ACIP, final ACIP vote, the one in December, that recommended 1B to be individuals 75 and older and frontline essential workers, the State Vaccine Allocation Committee made it very clear, its first meeting after that, that they thought it was a priority, a public health and an ethics priority to focus on congregate living. So that was a focus that really came from being concerned about overlapping risk factors, and it's related to an ability to isolate and to separate oneself from transmission. So to that extent, I think the state level vaccine allocation committee did a good job. Unfortunately, there had been news stories not too long ago that Wisconsin's rate of vaccination, while extremely good overall, had actually lagged behind other states significantly in terms of long-term care facilities. And I really don't know exactly why that is. The articles that came out really had a lot of finger pointing, the state pointing back to the federal government pointing back to the state. So it's really unclear why that happened. And I also just want to mention, in addition to that, that while in the talk I gave the state praise for making individuals with intellectual disabilities who are recipients of certain government programs, state level programs, access in phase 1B, I do want to say that just to be a little clearer about that, that phase 1B for that group started in March 1st. So not in January when it started for those 65 and older. And the reporting there has also been somewhat disheartening to see. Some recent reporting just on Saturday suggesting that many families who have loved ones who are covered under these programs and who have been eligible since March 1st have found it very difficult to find appointments, including difficulties even convincing vaccinators that they're eligible and have been eligible since March 1st. And that's, again, part of the problem with the decentralized approach to vaccination that has been unfolding pretty much everywhere. Different pharmacies have different paperwork, have different online portals for making appointments, and some pharmacies just didn't realize that individuals who are covered by these state programs were eligible. And so you'd go to their webpage and they would have, a decision tree or whatever, and you'd click this or that. And they had things for teacher and they had things for 65 and older, but they didn't have anything for being an IRIS or family care recipient. And so that's of course a real barrier to being covered. That's a real barrier to access even when you're officially eligible.
All right, Harry Brighouse was wondering, how did schooling and children's mental health factor into the categorization?
Yeah, that's a great question. My understanding is this. Phase 1B in Wisconsin started in January when all adults 65 and older were made eligible. And then the state basically broke the phase 1B into two parts. There was that initial part for individuals 65 and older. And then on March 1st, we're going to come a whole host of other groups. And the state made it very clear. Well, I'll come back to that phrase in a second. The state claimed that educators should be at the top of that next part of 1B. And so that led, those educators were eligible March 1st. And the state, as far as I understand, put vaccine in the hands of vaccinators and made it very clear that it was earmarked for educators. And my understanding is that virtually all educators who want to be vaccinated in, for example, Dane County, have been vaccinated. That was actually part of the reporting that was a part of the reporting that I was referring to that came out on Saturday, suggesting that individuals who are covered by, say, family care and IRIS, those individuals with intellectual disabilities, for example, were having difficulty being vaccinated. They were officially eligible on March 1st. But the state put out a document that made it very clear that they wanted educators to be at the front of the priority line under phase 1B. So it did this sub prioritization under the phases, and that confused a lot of people. And then the state came back and said, well, no, everyone we're listing under phase 1B section 2 is eligible, but we just wanted to make it clear that we're really interested in getting teachers back in classrooms. So that really made it very confusing for many vaccinators on who exactly is eligible. Now, this is a procedural issue, I think. This is an issue about not being clear and transparent about what the priority ranking is. But certainly that concern to get teachers back in classrooms, which I expect is related to concerns about children's mental health, definitely led to teachers being flagged for priority under phase 1B starting March 1st.
All right. Dareth Weeman asked a question saying the next level up from congregate living, jails, prisons, etc., are the folks who live in Section 8 housing. Because they qualify for Section 8 housing, they also have a very low usage rate of internet or other online registration or access to information. Where are those folks landing in the categories?
Well, at the state level, there is no special category under the phased vaccine allocation for individuals who receive Section 8 housing. If I'm not mistaken, Section 8 housing is a voucher program that basically enables people to pay their rent with a voucher. I hope I'm not getting that wrong. And many of these individuals, they're low income and they are more likely to live in multi-generational housing and therefore congregate living settings. So while they weren't officially made eligible under that congregate living residential setting in phase 1B, because that had referred to very specific categories, not this one. Certainly being a Section 8 recipient suggests that you are low income and you have these risk factors that will come with high social vulnerability. So you might expect very high Section 8 coverage in high social vulnerability areas. And instead of trying to use that as a priority, vaccine priority category, one could do just what Milwaukee did, which was to say, look, here are 10 zip codes that are extremely high in social vulnerability, which includes being high or low on the income ladder, which includes implies that you may well have trouble paying rent and paying for housing. And so we're going to make everyone in those zip codes eligible for vaccine access. That would be one way to reach people that you may think of as being eligible for Section 8, but also others as well.
All right. We've had a couple of questions about sort of lessons learned for the next pandemic, which, knock on wood, won't come too quickly. Christopher Olson asked, do you think that the COVID vaccine experiences will lead us next time to a more centralized or national system for prioritization and vaccine distribution for health emergencies? He says, I realize this is a challenge since most public health law is at the state local level in this country.
Yeah, that's right. That is a challenge. And I'm not an expert in this particular, federal state, policy making, and my prognostication is probably not worth much. I guess I would suggest, my guess is no, we wouldn't see much different. We might, at the state level, we might have learned a lot about when to get started. It's quite possible that a different administration might have focused on laying the groundwork, helping facilitate laying the groundwork at the state level for vaccine deployment. The Trump administration clearly did an extraordinarily good job in facilitating vaccine development, but they really showed very little interest in helping states with the actual allocation and deployment at the state level. And so I don't know if at the next pandemic we'll still be in a position where political party makes a difference to how that plays out. It may well. And so I'm not sure we will at the federal level have, we'll do anything different at the next pandemic. I sure hope that both, as Mike said, that pandemic is not around the corner, and that whatever it is at the state level, we learn the lessons that we're continuing to learn.
All right, so there's a message that says from host. We've got a couple hosts, but I'm guessing that's Tom. He said your talk focused on Wisconsin and US issues. Can you give a quick analysis of the international issues, especially comparing the US-UK approach to the EU approach in obtaining sequestering vaccines? And maybe just given your expertise, Paul, instead of talking about the politics and the policy, maybe do you have any ethical thoughts about the difference in terms of obtaining and sequestering vaccines between how the US and UK have been doing it and how the EU has been doing it?
Yeah, thanks for allowing me to pivot that direction. I mean, it's extremely difficult to figure out exactly what's going on when it comes to what the EU has access to and why they have access to it. So maybe, I can give you a couple examples where ethics certainly bears. I mean, on the one hand, there's intellectual property issues. The United States, I think, is expecting, the New York Times reported in the last couple of days that the United States, I think, government expects to receive a patent in the next couple of weeks that will be important for who can make a vaccine and under sort of what penalties of, violating intellectual property law. But setting even that aside, I mean, after all, having the know-how to make a vaccine is not the same as being able to make a vaccine. I mean, some of these vaccines are live viruses that need to be, produced extremely carefully. And of course, all of the vaccines need to be produced carefully with reliable supply chains. So it's not just the know-how, it's the ability to do it. But let me give you an example right here in the, our hemisphere, however you want to slice it. The United States right now is sitting on tens of millions of doses of the AstraZeneca vaccine. That vaccine is not approved yet here in the United States, but it is approved elsewhere, the EU and in other countries in our Western hemisphere. And as far as I can tell, the United States is not super eager to give up access to these millions and millions of doses that we probably won't use. They seem in the last couple of weeks, maybe the Biden administration the Biden administration has suggested that maybe they're willing to make a trade. Maybe they're willing to give up some of these doses to Canada and Mexico, but in exchange for vaccine that they'll give back to us at some point in time. It's really unclear, with things raging in, Mexico and Brazil and Canada still, not quite where we are at the level of vaccination. It's really unclear why we wouldn't just, and from an ethics standpoint, I think we should just give away the doses that we have. Why we need to insist on some sort of reciprocity for vaccine that we very likely won't use in the middle of, resurgence in many parts of the world is kind of a mystery to me, and it seems like an ethical no-brainer to give them up.
All right, Stephen Sentoff said, opening up eligibility to large groups seems to automatically advantage people with better access to technology. And Diana Lutz chimed in that it's kind of a scrum out there as far as getting a hold of appointments and things like that. So Stephen's question was, wouldn't phasing across smaller groups be more equitable and limit some of that technological advantage?
It's absolutely true that depending on what your large group is, people in that group, there are going to be certain portions of that group, and then other people who might come later outside of that group who face, disparate access to technology. And that's absolutely relevant to the equity and efficiency of vaccine allocation. After all, you might get shots into arms quicker if you give it to people who are quick with a mouse click. That doesn't mean you're going to do the most good with the shots that you have. On the flip side, however, having smaller groups might mean that you're waiting for members of those smaller groups to come, reach out to you in whatever way you've established. And that might mean you end up sitting on doses of vaccine for longer than you would like, even from a public health standpoint. So one way to sort of split the difference there is to go in for something like what I was calling a place-based approach. You can make vaccine eligibility open to a wide group, and you might have some people within that group more likely or able to get internet-based appointments. But that doesn't mean that you can't also at the same time go to communities, bring vaccine there, make it very clear with phone calls and text messages to reach people who don't have reliable internet access, but who do use phones, for example, do use text messaging, and let them know that there's a vaccine clinic near them, or there will be next week, and here's who you can call to get an appointment. All of those are ways of reaching groups that are marginalized, that face barriers to technology. And so I'm not sure having smaller group phases solves this problem, but certainly proactive outreach and place-based vaccination would.
So there have been a couple questions about ethical issues related to vaccine hesitancy. Folks perhaps from particular demographic groups who are reluctant to be vaccinated. So maybe I'll just say to you, Paul, what are sort of the ethical issues you see around that point?
Yeah, I mean, that's a great question. Before we had any specific vaccines authorized for use in this pandemic, there were, studies done sort of on hypothetical, vaccines. And those studies, for example, showed greater hesitancy on the part of, say, African Americans compared to non-Hispanic whites, just to give you an example. We really saw those differences sort of vanish. I mean, probably not completely, but dissipate quite a bit when there was an actual vaccine, or when there were actual vaccines that we could talk about, their safety profile. So I would say, so that's one factor. Another factor is that there is no question that, for example, the African American community in the United States has legitimate concerns to be hesitant and skeptical about the deployment of public health, where they're being recruited or encouraged to undergo a medical procedure. We have instance after instance of this country where people have been misled and exploited. That said, yes, there is this degree of hesitancy, but hesitancy is not the same as outright refusal. It just takes outreach, it takes communication, it takes people who they trust to let them know that they have trust in both the vaccine and the system. I spoke with a CEO of a community health center on the north side of Milwaukee, and I asked her about the Tuskegee syphilis trial, where African American men were misled into joining a trial where they thought they were getting treatment for their syphilis, and instead the U.S. Public Health Service just wanted to watch what happens when untreated syphilis goes years and years and years. And in addition to that, when these men were drafted for World War II, where they would receive a physical and treatment, the U.S. Public Health Service made contact with the doctors who would treat them and said, no, please don't treat them. They're part of this federal government experiment, and they didn't get treated. So that's just one example of an abuse. That said, that leads to legitimate hesitancy, but it should not be confused with refusal. And it may take focused and concentrated outreach. And this, let me circle back now to the CEO I spoke to. She said to me, Paul, yes, there's hesitancy, of course, but they trust me. They come to my clinic. They know that I have advanced degrees. The thing that worries me is if I make a promise that there's going to be a pop-up clinic next week and it doesn't happen, then they're going to have real distrust with the system. And that's really going to be a problem for public health in our community. And so there's hesitancy and hesitancy and hesitancy, all coming from different concerns. And it really does take special attention to all the reasons to make sure that hard to reach populations are reached, especially when they happen to overlap with the populations that have borne a disproportionate burden from the pandemic.
I had a question myself, and then we'll get to a couple more in the chat. So I think there was a big media fanfare a little while back about including smokers among at-risk populations, right? And my read on that was that this is actually a really interesting ethical question. On the one hand, you have this group of people who probably medically are higher at risk for various complications and mortality. On the other hand, there's this pushback because it's perceived that these are people who made a choice, and now instead of, in some sense bearing the consequence of their choice, they are being prioritized, or some might even say rewarded for this choice that some people would see as a poor choice. So it's a really interesting conflict of ethical values in making that decision on whether to include smokers among one of the prioritized groups or not. Just do you have any thoughts about sort of how you make that ethical decision and work your way through that problem?
Yeah, I do. I mean, this one hits close to home for me. Both of my parents were smokers and both quit, but only eventually after many, many attempts. And they both started smoking very early. I mean, I don't want to out either parent, and I might not be accurate about it, but the vast majority of people who smoke started smoking before the age of 18, before the age where we give people the right to vote because we're concerned about their decision-making capacities. At the same time, they were, seducted into, many of them were seduced, rather, is the verb, into smoking by very savvy advertising campaigns. And so you can sort of see where this is going. I have a very hard time condoning, endorsing the argument that smokers should be held accountable for their behavior when the behavior is very clearly an addiction, much of the time begun before we credit individuals with the ability to make sound decisions for themselves. And so at the same time, it is a vulnerability. The addiction itself is a medical problem. What smoking brings is a medical problem. And if it happens to be a risk factor for adverse COVID-19 outcomes, I have, I'm in the camp of not holding it against smokers. That's not to say I'm not ever willing to, quote unquote, hold behavior against an individual in the context of allocating a scarce healthcare resource. I just think it really matters what the condition is and how it arises.
We've had a couple of questions about distributing vaccines to children. And I noticed in one of the slides you put up, the National Academy recommendations, I thought was really interesting because I think they had all children in phase 3 and then a huge group of adults in phase 4. And so at least in those National Academy recommendations, a lot of children, if we had followed those recommendations, would have gotten vaccinated before a lot of healthy adults who didn't fall into other categories. And yet that's not what we're seeing in the way that it's actually playing out in the States. And so there's some questions in the chat about, could you at some point vaccinate children through schools the same way that university students are being vaccinated through their university health systems? And just in general, why have children sort of gotten placed where they got placed? Is it purely a practical issue, or what's happened there?
Well, I think the quick answer is that no vaccine is approved for any person under the age of 16. And so that already, excludes a significant portion of people that we file under the heading of children. I haven't been monitoring the chat, but as far as I'm aware, the only students at University of Wisconsin-Madison who are being vaccinated are students whose education puts them in a position of being a healthcare provider or support or interning in a healthcare setting. No student who doesn't have that connection to the existing phases, phase 1A and phase 1B, has received a vaccine. So I guess it is an interesting point, Mike, that the National Academies has children and young adults in, I was just pulling it up on my computer, phase 3, and then phase 4 is anyone who's, who hasn't been captured by the other phases. I wonder if we had actually gone forward with the National Academies prioritization, would there be anyone in phase 4? It's unclear to me. It may be that we learn more about what this disease does to children, even though it seems like it spares them the worst and that they're more problematically a vector for others. If we learn more, then I can imagine, there may be prioritization. But right now, as best as I can tell, the trials have expanded to children, and we're waiting to see if they will get approved for use in individuals below the age of 16.
Just for those of us who don't know as much as you about how vaccine trials work, why is it that the trials have only just started for children and they started, months and months ago for adults?
Yeah, that's a great question. I actually don't know the full answer to that. I mean, I can imagine on the one hand, we knew when things got started that it seemed to, or we thought we knew that it spared children. there are rare complications. There's an inflammatory syndrome that is rare in children that is certainly concerning and shouldn't be dismissed, but the deaths were coming from adults. Those are also individuals, adults or individuals who can give consent to be part of a trial. Children, parents would have to consent children, and it's possible that Operation Warp Speed and the drug developers, pharmaceutical companies, didn't want to navigate that process. After all, they were trying to move fast. So that might have accounted for it. I could see it reasonably accounting for some of it. I don't know the full answer. I think we were trying to get these trials going quickly. Any trial participant has to be contacted. Any potential trial participant has to be contacted, consented, gone through the process. And, those are hours and hours and hours for each individual. We needed to get this done fast. I could see, speed and expediency being a key reason why we have it approved for 16 and older. And we're only now investigating these vaccines in younger communities. But it may be that there are other reasons. And if those in the chat know of other reasons, please drop it in there.
So we've spoken a little bit about how our experience with this pandemic might inform our future decisions about future pandemics. There's a good question about how what we're doing right now has been informed by previous national programs to vaccinate the population. The obvious example that Dareth Weeman makes in the chat is the effort to vaccinate people against polio in the 50s and 60s. But there have been other smaller scale vaccination efforts. So what, as far as past vaccination efforts, were you all looking at when you were going through this decision-making process?
Zero. I mean, at the ethics committee level, we were not looking at past vaccine allocation efforts. All of these meetings are public, so I feel like I feel comfortable telling you that. At the ethics level, we felt like we were in a position to start with ethics documents that have been used on the heels of say the H1N1 epidemic. That 2008 document that I started with came on the heels of it, but that document wasn't clear about what aspects of the H1N1 epidemic it was responding to, and we were mostly responding to the ethics of it. As at the state level, and I'm not sure this came through in the talk. The state really did take the reins away from, to a significant degree, away from the vaccine allocation committee. That committee made its recommendations, but the state made many changes to that and is still making changes. That committee went on hiatus in late January, early February, and as far as I know, hasn't met again. All the while, the state is on the fly making new groups eligible. I'm not sure if the state is looking backward. I think they are having, they have their hands full dealing with the moment. Whether or not looking backward could have improved on what happened, again, I don't know that either. Polio is obviously a historical precedent, but it took many, many years to develop that vaccine. Certainly much longer than the whatever it was, 11 months or whatever it was to get the first two mRNA vaccines. That said, I have seen some historical accountings of how many people, say the city of New York, and were able to vaccinate in both context of smallpox, for example, and then also in the context of polio. It definitely gave some inspiration for how quickly the state of Wisconsin could move. And we're at, as far as speed goes, we're almost the fastest in the nation, from what I can tell. We have the smallest proportion of vaccine that we've been allocated left and not in arms. So speed hasn't been the issue. The issue really has been who gets them, who gets priority. And honestly, I'm not sure there was a lot of looking backward at past public health emergencies for that. I could be wrong, but I don't think so.
Yeah. So another question from mysterious host. And this is a question about the AstraZeneca vaccine. And there have been these concerns about side effects that now look to have been unfounded. But certainly a number of EU countries stopped using that vaccine. So maybe can you talk a little bit about, how concerns about side effects, first of all, sort of complicate the ethical picture, but then second of all, complicate the sort of rollout picture to the wider population?
Yeah, this is a real head scratcher from an ethics point of view. I mean, the adverse events are still very sort of proportionally very small, and it's, there's nothing definitive to suggest that it really is a side effect of the vaccine, as opposed to just being, a background noise that would have happened anyway. And here's the key ethics point, though. Even if the AstraZeneca vaccine increased the probability of having some adverse blood clotting event, still the probability of that, in light of the numbers we're seeing in reporting, is still very small. And at the same time, COVID-19 is still extremely dangerous. And so what you have is a sort of cost-benefit risk analysis that every individual should make for themselves about whether or not they're concerned more about this marginal increase in blood clotting versus the marginal protection that they would get from having a vaccine that is more than 70% effective. And to put a hold on allocation when at the end of the day, every shot that goes into every arm is a voluntary choice that an individual makes for themselves, is really hard to understand why you would deprive thousands and millions of people of the ability to make that choice for themselves. I mean, we can connect this to the discussion here in this state that many people are having about when and whether employers or other entities should be able to require a COVID-19 vaccine. Well, even if you thought there were contexts in which mandating, in that sense, a vaccine could be justifiable, no one is going to do it in the context of, or very few entities are going to do it in the context of a vaccine that is not fully approved by the FDA. And as many people on the call know, these vaccines that we have available to us are authorized under an emergency use authorization. So we all know that this is something that we have access to by virtue of an emergency. It's an emergency that a community has, and it's an emergency that every individual has, some worse than others. So I have a bioethics colleague, Govind Prasad, who in a news story likened the suspension of the AstraZeneca distribution in Europe to pulling the ladder away from someone who's trying to, his example was trains, because he was trying to make a trolley problem analogy. But I mean, you can imagine the same thing with a fire, basically saying, well, some people are, there seems to be an increased risk of, spraining your ankle on this ladder. So let's pull it up while you're trying to get away from a much more dire emergency. The ethics of that doesn't seem very compelling to me. And, it really will make a big difference to what happens to resurging coronavirus epidemics and outbreaks across the world for communities that have done that.
Yeah, great.
Someone put
point out. Oh, go ahead.
Someone put in the chat, here's the story, not students.
I was just about to say about that, but you can go ahead, Paul.
I'm fairly certain that the answer is that's right. The only students are students who have some connection to healthcare, the healthcare setting. Those are students who are doing practicums, nursing students, and the like. Everyone else is a staff member who is 65 and older. Maybe now we're at 50 and older. Faculty who are meeting, who have direct contact with students. Right. The university has now moved to any staff that has face-to-face contact with students. I am not currently myself officially eligible as a faculty member who is teaching entirely from Zoom. And I think it's going to be a long time before we're able to, by a long time, months, a month, two at the very least, that UHS is able to, University Health Services has vaccine on hand to give to students after it's gone through its priority ranking. So I'm pretty sure that number doesn't include students who don't have some clear documented connection to healthcare delivery.
Yeah. Just to explain to everyone what the number is, if you haven't seen what we're talking about, there was a link put into the chat to a story that UW-Madison has given out more than 10,000 vaccine doses. And I think the point Paul's trying to make is you've got an awful lot of people at UW-Madison, and many of those are staff. I mean, you've got thousands of staff people at UW-Madison, and you've got, I don't remember what the number is, but upwards of 30,000 students. So those 10,000 vaccine doses, I would say most of them have in fact not gone to undergraduate students, for instance. There's a very limited number of undergraduate students who are getting those doses. And you've got to keep in mind that UW-Madison includes a number of health facilities and other types of frontline workers. So that's worth keeping in mind. Christopher Olson also reported in the chat that just about the question about why the trials on children started later for the vaccine, that he says the new vaccine approval system in the US always starts with testing in adults before children. Even for vaccines targeting childhood infections, initial testing will be in adults. A part of this is the view of children as privileged and to be protected until overall safety is established in adult human beings. The COVID vaccines are now being phase 3 trialed in children down to 6 years of age in one case and down to 6 months for another vaccine. So there's interestingly a partially ethical explanation of why we do the vaccine testing in the order that we do. Yeah,
that's right.
I think we should probably wrap it up there. I think this has been great, Paul. Thanks for the presentation and thanks for answering all these questions. And, Paul invited folks who want to follow up with him to, by all means, contact him via email. But for right now, we're going to close it down. So thank you very much, Paul. It's been great.
Thanks, everyone. Thanks for coming. I appreciate it. And yeah, by all means, connect with me if you want to talk more.
Great. Okay, I'm going to shut down the live stream.